Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Hello and welcome everyone back to Quorumcast. Today's episode is back to the cardiology topics, and today I will talk about hemodynamics, touch on the physiology and also on some medications. So it's a really key, crucial, important topic, and we will discuss and have some repetitive knowledge about hemodynamics. So I hope you are all ready to head into the topic. Hemodynamics, what is it? So it's mostly about cardiac function, mostly about blood pressure, heart rate. It's crucial to evaluate the status of the patient, and it's also, if it's unstable, the hemodynamics for any reason, then the patient is in huge trouble and needs immediate action from the medic self. So, how to evaluate the hemodynamics? What is it? So, just by approaching a patient, you can get tons of information on hemodynamic status. Just for example, if you speak to them, if you say good afternoon, then you can notice the reaction of the patients, whether they are oriented, disoriented, whether they can talk to you or they are not able to answer your questions. So if they are oriented and can speak to you, then you can assume that there is no major instability in the hemodynamics. Also, with a blink, you can decide, is the patient pale, is he blue, cyanotic, have a normal appearance on the skin that suggests a normal hemodynamic status. So these are just by approaching the patient, having a blink, you can get information. Next, when you do the first ABCD assessment, of course, you get lots of proper data, proper measurements related to the hemodynamics. What are these? Of course, heart rate, then the river-occipital blood pressure, then you can check and you do the CRT. These are really the basic measurements in ABC. Then you can also ask a bit about the diuresis of the patient. If they are elderly, you can try to get some hints how much of fluid output they have. And it's also really useful in pediatric care, or you can ask the parents if the babies are still wearing the nappies, how many wet nappies they had that day, tons of information, because if the hemodynamics are unstable, first sign would be the decreased amount of urine. Then the next step is on an upper level of the measurements and the diagnostics, mostly used on ICU cares and not in the pre-hospital settings, but I would like to mention is the arterial blood pressure monitoring, where you have a pressure monitor, a pressure monitoring device, set it into an artery. It's mostly the radial artery, and you can have on your monitor the arterial curve. You can also exactly measure the diuresis. Some of these devices come in intensive transport. So when a patient from an ICU is transported to another ICU, secondary transport, but predominantly these devices are not used in the pre-hospital care. Okay, so next I would like to discuss some definition just to make sure that we know what we are talking about. So what is the preload? So it's the amount of blood, the volume of blood flowing into the heart, into the right atrium and right ventricle. It's also known, and then to the left ventricle, it's also known as the end diastolic volume. What is the contractility? It's the exact force of the myocardial muscles to make the contractions, and the contractility itself is independent from the preload or the afterload. What is the afterload? So it is the resistance against the myocardial force, the myocardial contractility. So the afterload itself is the resistance in the systemic vascular system. All right. Then we need to discuss the MAP. MAP, it's mean arterial pressure, which we can calculate by the cardiac output and multiplying it by the systemic vascular resistance. What is the cardiac output? It is the stroke volume multiplied by the systemic vascular resistance. Then we have to always differentiate between a vasopressor or an inotrope drug. Vasopressor it means it increases the vascular resistance. The inotrope means increases the contractility. And we also have the chronotrope, which means increasing the heart rate, and the lusitrope, which means increasing the diastolic function of the heart. Okay, so vasopressor, inotrope, chronotrope, and lusitrope. All right, the hemodynamics can be unstable for quite a lot of reasons. It's also unstable when the blood pressure is too high. That's a hypertensive emergency, and in today's session, I don't want to touch on that. Rather, I would like to turn to the phase when it's too low, and the instability of the hemodynamics are for a cardiac reason or for non-cardiac reasons. The cardiac reasons are more common. For example, heart failure, an infarct, myocarditis, pacemaker dysfunction can cause unstable hemodynamics. Or in a non-cardiac reason, sepsis is the most common, or neurogenic shock, obstructive shock, etc. Okay, from here, let's turn to the medications. And in general, it's important to note that the medications acting on the hemodynamics are acting on receptors located mostly in vascular walls or on myocardial muscles. And the drugs can rather be agonists or antagonists acting on these receptors. Okay, from here, I would like to discuss the medications mostly used in hemodynamic instability. First of all, let's start with the adrenaline. Adrenaline is widely used. It's the most important medications of an ALS scenario in CPR, but it can also be used in ICUs or in pre-hospital care in other situations as well. I can say that adrenaline would not be the first choice in a non-CPR situation from me. So yeah, I would go for other inotropes or vasopressors. So, but the adrenaline it acts on an alpha and beta adrenergic receptor, so on both receptors, and adrenaline acts as a complete agonist on both receptors. In lower dose, which means 0.1 micrograms per kilogram per minute, its effect is dominant on the beta receptor. And on this receptor, the adrenaline increases the cardiac output and also highly increases the myocardial oxygen demand released to the increased cardiac output. And for this reason, it's also really arrhythmogenic. In higher doses, which means 0.2 micrograms per kilograms per minute, the effect is dominant on the alpha-1 receptors, And these alpha-1 receptors are located mostly in the peripheral vascular system, peripheral arteries. So and also has an agonist effect. So on an alpha-1 agonist, the adrenaline causes a potent, really strong vasoconstriction. And by this, it increases the systemic vascular resistance. Okay, adrenaline has another well-known effect, which can be really useful in asthmatic patients, that on the beta receptor stimulation, it has a strong bronchodilatory effect. So it results in a bronchodilation in the bronchial system, and it's not related to the hemodynamics, but important to note that increases blood sugar levels in a potent way. All right, so this is adrenaline. As I mentioned, I rather keep it for CPR situations, and it's not that common on not on ICUs. Okay, the next one to discuss is the noradrenaline. The noradrenaline is also an agonist on beta and on alpha 1 receptors. On these receptors, the agonist effects results in increased systolic and diastolic pressure. And it's important to note that with noradrenaline, we can count on a reflex bradycardia. It's a strong peripheral vasoconstrictor, mostly on the alpha-1 receptor. And unfortunately, one side effect or one complication related to prolonged and high dose noradrenaline use in ICUs could be a limb ischemia. So it's important to early notice this side effect. It also decreases the splanchnic and renal arterial flow via these vasoconstrictory effect, and it's also a hazardous complication on ICU patients. It's really, really widely used in sepsis, and it's important to outline that the noradrenaline is a strong vasopressor medication, but it has no direct inotrope effect. We can turn to other medications and discuss those which really keen to be used on cardiac ICUs. These are the dobutamine and dopamine. I would start with dobutamine because dobutamine, it's the first choice, and nowadays really widely used, and it's the most feasible drug in acute heart failure when there's hemodynamic instability. It has a direct beta 1 receptor agonist effect, and also really slightly, but also has an effect on the beta 2 receptors as an agonist as well. So it's a beta receptor specific. And on these beta 1, beta 2 agonist effects, it increases the contractility, increases the heart rate, and by acting on the beta 2 receptor, it decreases the systemic vascular resistance. So it's extremely helpful, friendly environment for the failing heart, that there's an increased contractility, an increased heart rate, so increased stroke volume, increased cardiac output, and by decreasing the systemic vascular resistance, there's a decreased afterload, so the heart would not suffer that much when on dobutamine. But due to this decreased systemic vascular resistance, sometimes it's a need for co-administration with noradrenaline to maintain a stable MAP. Okay, so dobutamine, remember, first choice in acute heart failure, and also remember that it has a decrease, it has an effect on the systemic vascular resistance, which is a decreased effect. Okay, big brother, the dopamine, which is the older brother, I can also say. The dopamine for really, really long while, it was the first choice in heart failure. But nowadays we know that the dobutamine is more feasible, and there are not so many complications, not so many arrhythmogenic effects. So the dopamine, it's a potent agonist on beta 1 receptors and also in dopamine receptors. And it's also the precursor of the noradrenaline synthesis pathway. The dopamine increases the cardiac output, the stroke volume, and also the MAP via increasing the contractility and also increasing the coronary flow. There's a huge increase also in the myocardial oxygen demand. When it's administered in high doses, high means more than 10 micrograms per kilograms per minute, it has predominantly peripheral effect and increases the systemic vascular resistance. Used in sepsis, sometimes in heart failure as well, still nowadays. Okay, and approaching the end of today's session, I would like to discuss a relatively new medication, which is called levosimendan. The commercial name is Simdax. It's a new magical drug in acute heart failure. It's really expensive and it's not so widely available. I've never seen it so far never in pre-hospital care, but I think that they will also come. So what is this levosimendan? It's a drug which increases the calcium sensitivity of the failing heart, the failing cardiac muscle. It has a positive inotrope effect by increasing the stroke volume and also the contractility. And its major benefit is that it reaches increasing stroke volume and increased contractility without increasing the myocardial oxygen demand. It also has a lusitrope function, so it increases the diastolic function of the heart as well. The indication is acute heart failure and no other indications so far. Okay, this short summary, I hope that it gave you a short summary on the hemodynamic physiology, how to get a quick impression on the hemodynamics, how to get proper diagnostics, and then if there's a hemodynamic instability, meaning decreased contractility, decreased blood pressure, etc., which drugs you have on hand to choose. Of course, we didn't discuss today, but you all know that these medications have to be administered with an infusion pump. You should avoid bolus administrations if it's not needed, for example, in CPR situation, because the effect are really prompt, coming in seconds. The half-life of these medications are relatively short, 2 to 10 minutes, so you need a stable infusion pump to be used, and mostly these medications are administered via central venous line, so not to the periphery, most of them, but mostly the dopamine, also noradrenaline, so they can cause severe necrotic effects in the tissue when it's administered in a peripheral vein and when there is a paravasatum of the drug. I would like to also outline just a practical advice that dopamine and dobutamine should never be co-administered with furosemide in the same line. So they can be co-administered, but then you need to use separated IV lines, because dopamine and dobutamine, they cause some chalates with furosemide, so none of your medications will work, and you will be mad because you won't know what's the problem, or you will feel that the patient is deteriorating despite your huge demand on dobutamine and dopamine. And the reason is that they were co-administered with furosemide in the same line. So when you co-administer dopamine and furosemide, or dobutamine and furosemide, you need to label the IV lines, and you need to use separated lines for these. Okay, yes, I hope that this summary was useful. Always check the dose. There are really long tables of these inotrope or precursor drugs, and you can set your warranted amount, your warranted dose, and you can calculate for the weight of the patient. So you should keep these, you can keep it in your mobile as a photocopy or whatever it's suitable for you, or you can keep it in your pocket in your pre-hospital bag, but make sure double check the dosing of these potent medications. Okay, thanks for staying with me today, and please continue to listen to these Quorumcasts.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Quorum, Corom, Quorum.org.